owners and their custodianship of the lands on which I am at the moment, which is the lands of the Jagera and Turrbal people, and also the lands of the Awabakal country, where Michelle is sitting at the moment. It's my absolute pleasure to introduce Dr. Michelle Jackman. Michelle is an occupational therapist from the John Hunter Children's Hospital in Newcastle in New South Wales in Australia, who has combined her clinical role with a postdoctoral research fellow position with the University of Queensland. Michelle has a special interest in providing evidence-based interventions that lead to real-life improvements for children and families that we work with. Michelle's research is focused on goal-directed interventions for children and young people with cerebral palsy, and she's excited to present the recently published international best practice guidelines to support functional goals for children with cerebral palsy. And I'll hand over to Michelle.
Thanks so much, Leanne. Like Leanne said, it's really exciting to be able to present these guidelines to this group, who I assume is really beautifully well informed already, so it may not be new information, but there was a big group of us working on these guidelines for sort of about 3 years, and they were finally published in the last 12 months or so. So today I'm going to be presenting on these international guidelines that, like I said, were developed by a really huge group of clinicians and researchers as well as consumers. So certainly not just my own work, and I'd really just like to acknowledge all of those people who contributed to this guideline across Australia, but also across many continents all over the world. So a number of years ago, the international cerebral palsy community, including people with CP and their families, as well as clinicians and researchers from across the world, came together to identify really key areas that they felt would make the biggest difference to the lives of children and young people with cerebral palsy. And the first two priority areas were around early identification and early intervention in CP, and guidelines for both of these things were subsequently developed. And the third priority was how we improve functional goals. So the things that children need to or want to do throughout their day or their week. So things like getting dressed in the morning, riding a bike, playing basketball, drawing, heading to the shops with their friends, learning to cook, or any other interest that the child might have. So, you know, as probably most of you are probably aware, these guidelines are really, really important because evidence and our idea of what is best practice in this area has really changed and evolved a lot over the last 20 years. So before we get into these guidelines, I'd love to introduce you to Ivy. So this is her in the middle with her parents and her younger sister and older brother. Ivy has bilateral CP. She's classified as a GMS-CS3. She uses a powered wheelchair actually for the majority of her mobility, and her hand function is pretty poor. So she's got quite significant spasticity in her upper and lower limbs, combined with some underlying dystonia. So she also has numerous joint contractures. So I suppose as clinicians, if it's clinicians primarily that are out there, it'd be great for you to have a think about what is the first thing that really comes to mind that you might address to support Ivy. So as health professionals, we often, I think, automatically jump to conclusions about what the best treatment options are for children and young people based on their diagnosis, perhaps, and those underlying impairments. And certainly families who have been in the healthcare system for many years might think the same. So for Ivy, we might automatically think about, you know, managing her spasticity and contractures and ensuring that she maintains as much joint range as possible and that sort of thing, right? So hopefully this audio works. So we'll hear from Ivy about what's important to her, as well as Ivy's mum, Michelle, who really comments on the importance of having, I suppose, easily accessible information on the best available interventions for their kids.
I'd like to be either a surgeon or a drama teacher, and I'd like to have a whole house controlled by Siri.
It's really difficult to navigate all of the information that's out there. I think it's really important that we do research as a parent ourselves.
So I don't know if you guys could hear that very well, but Ivy was telling us that when she grows up, she'd love to be either a neurosurgeon or a drama teacher, and she'd love to own an entire house controlled by Siri. And her mum, Michelle, was really highlighting the importance of parents and families being given information about treatment options. So we heard about Ivy's long-term dreams, and right now Ivy loves playing with friends and hanging out with her family, and she loves fashion and all the other stuff that, you know, 10 or 11-year-old girls are interested in. So as clinicians, guidelines, then how do you think we can best support Ivy to achieve all of these goals that are really important to her at this point in time? Do you think that, focusing on improving joint range or building strength and balance skills will lead to Ivy being able to, go bike riding with her family, or head out to the shops for a new outfit with her friends, or eventually become a neurosurgeon with a mansion controlled by Siri? And we know from research now actually that the answer to that is probably not. We need to actually focus directly on the person's goals if that's what we want to achieve. So this idea of functional goals was really brought about, it was really brought to the forefront, I suppose, in medicine and healthcare with the publication of the World Health Organization's updated International Classification of Functioning, Disability and Health, or the ICF, which really challenged us as health professionals to consider whether the interventions that we were choosing to treat or help people with any health condition really were making a difference to what really mattered in the life of that individual and the family unit around them. So the ICF told us that, no longer was it best practice to treat two people with the same condition in the same way. And in fact, those two people might have completely different priorities and interests and lives. And that as health professionals, it's really important for us to consider this rather than just thinking about a diagnosis. So whereas previously in healthcare, the primary focus was often on body structures and functions, so in regard to treating someone with cerebral palsy, our primary considerations might have been spasticity and joint range. It's now really recognised that in addition to thinking about those underlying conditions, it's really, really important for us to think more broadly about what might be limiting our clients' ability to achieve their goals. Because our ability to do the things that are important to us aren't just influenced by how our bodies move or how we think. The activity we are doing, or who we're doing the activity with, and the environment we're doing it in, are really, really important and critical considerations for participation in these really important life activities. So we used to think that focusing on underlying impairments such as joint range or muscle strength or balance or sensory processing skills, for example, would have a direct impact on activities and participation. So those things that were really important to each individual or client that we're working with. But in actual fact, research is now telling us that unfortunately this might not be the case. So current research suggests that improving underlying impairments does not necessarily lead to improvements in those real life activities. And in fact, it's really important that we consider much more about the person, the goal that they want to do, and the environment that they want to do it in if we're likely to be able to help with participation in those things that are important to that person. And this was one reason why it was really important to develop guidelines around improving function or real life goals for children and young people with cerebral palsy, because like I said, the evidence around best practice in this area has really changed a lot over the last 20 years. So interventions to improve function are those interventions whose primary purpose is to improve the ability to be able to do a day-to-day activity or participate in some important aspect of life. So in the definition of this guideline, function is something like being able to open the milk to pour it on your breakfast cereal, or ride your bike to school, or go dancing with your mum, because that's what's really, really important to you and your family. So function is not being able to extend your wrist or get your heel all the way to the ground when you're walking. These are actually component skills that we would consider within that body structures and functions or impairments domain of the ICF. So interventions that are passive, or interventions that might involve the child actively doing something but do not involve the child actively actually practicing the real life task, were not included in this guideline. And that's because they don't fit with what evidence is telling us about what leads to improvements in function. So this might include interventions like virtual reality or Mai Tai or NDT and bow bath, or a focus on changing sensory skills, for example. So before I get into the guideline recommendations, I'll really briefly mention the guideline process that was followed, as this was a really vigorous process using the GRADE, which is Guideline Recommendations, Assessment, Development and Evaluation approach, which is really a method for assessing the certainty of evidence and strength of recommendations in healthcare. So GRADE is really considered the international gold standard in guideline development. So as clinicians, if you're clinicians out there or families, we all know that the amount of evidence out there can be really, really overwhelming. And the purpose of a clinical guideline is really to do the research hard yards for us. So for this guideline, a team of researchers in consultation with expert clinicians from across the world, as well as consumers, have collated the evidence regarding therapy interventions and combined this with information about accessibility and cost effectiveness with the preferences and values of children and young people with cerebral palsy and their families, as well as clinicians who work in the cerebral palsy field, to come up with guidelines to improve function for children and young people with CP. And I think as a researcher, it's really exciting to work on something like guidelines, because the whole point of a clinical practice guideline is to come up with recommendations that can actually be immediately implemented by clinicians. It's not like some other research that, you know, we might read as clinicians that you think, how can I actually implement this in my own practice? So after this rigorous guideline process, there were a number of recommendations that were made for clinicians to aim for in clinical practice when we're working with children and young people with cerebral palsy who have a functional goal. Recommendation 1 is that the client chosen goals should be set. So intervention should always begin with understanding the child's functional goals and understanding what's really, really important to that child within their family. So goals, I think, are such a critical step, and one that can often be a bit rushed. But without setting goals, it's really hard to know what our intervention is working towards, and therefore really hard for our intervention to ultimately be effective. So I think it's really important not to underestimate the power of really taking time to beautifully understand a client's goals. Where possible, children should be asked what is important to them. So this might be a bit different to how some people set goals in practice. Sometimes clinicians decide what is the most important thing to work on, and sometimes families really lead this process. But it may be important for us to consider whether the children that we work with, especially young people, and especially, you know, those people that we work with who have lifelong disabilities, who might be having therapy for their entire childhoods and child lives, whether they should be given the right to choose what they want to do more easily or get better at or focus on in therapy. And research really tells us that motivation is significantly improved when children are able to set their own goals and have some control over that goal setting process as well as over intervention. And this really in turn improves adherence to home practice ideas and ultimately improves how effective our interventions are. So sometimes children aren't able to identify their own goals. And if this is the case, families should definitely be engaged to set goals which consider the child's preferences and interests. So for children, for example, who aren't able to communicate, it's really important to try and understand what they enjoy and really empower families to feel like they can set goals and priorities around things that their children really enjoy doing. Goals should be functional, well-defined, achievable, and measurable. So when we set goals that are really specific, it actually makes it easier for children and families to go away and practice those goals, as well as having that joy of success when they actually meet those goals. So rather than the goal being, you know, Sarah will carry out transfers, a goal of, you know, Sarah will be able to independently transfer from her bed to her wheelchair is something that's really more specific to work towards and potentially more achievable than a general goal. So goals should be incremented according to the child's level of ability and progress. And this really speaks to the importance of not setting goals that are too far out of reach. And it may be that we need to spend a little bit more time incrementing larger long-term goals to make them more realistic. It's beneficial for a written copy of the goals to be given to the child and the family. And this is such a simple thing, but I think so many families comment on how useful it is to have a reminder on the fridge or on their phone of what the goals are that they're working towards. And it's really important for us to measure goal performance at the beginning and the completion of an intervention. So children and families put so much time and effort into practicing the therapy recommendations that as clinicians we make and the home programs that we give. And being able to measure the success of a goal at the end and really get recognition for the clients for all the hard work that they've put in is a really, really important part of intervention. And it's also really, really important for us as clinicians to know whether our intervention has been effective or not. And if it hasn't been, what alternative interventions we might be able to use or how we can address goals differently in future. It's really important for us to make goals that are functional and reflect what is important to the client. So sometimes this can get lost in the NDIS goals, I think, which is a bit of an issue in Australia at the moment. But as health professionals, you know, we have this really beautiful skill set of goal setting that we shouldn't dismiss just because an NDIS plan, you know, has a non-functional goal on it, for example. So to be a functional goal, the goal itself doesn't focus on an underlying skill or impairment, even if those underlying skills or impairments are something that we as a health professional might have considered and feel that we need to work on during the intervention. So there are some examples on the screen here of goals that are functional versus goals that are focused on underlying impairments. So the functional goals really reflect what the child wants to do, not what we as the therapist might want to focus on to work towards that goal. Recommendation number 2 is that clinicians should observe the child carrying out the task or goal in order to determine the factors that are limiting goal achievement. So this seems really simple, but I think it's often a step that can be overlooked. So observing what the child can currently do is about understanding where a client is currently at and targeting the intervention really specifically for that client rather than, giving general information or recommendations that might not necessarily be effective. And it's about us not assuming that an underlying impairment such as strength or range of motion or balance, for example, is the thing that's actually stopping someone from being able to achieve their goal. So these things might actually need to be addressed, but as I mentioned, addressing these things may not actually improve the ability to do that goal if they're not practiced within the context of that goal. So it's really important for us to consider not just the client and what's happening with the client's body, but also the actual task or the goal, as well as the environment and how these things might be impacting on the person's ability to carry out that goal. I think that bike riding is a really great and simple example of this. I think often if a child isn't able to ride a bike, we automatically assume that they need to work on their balance and their leg strength, for example. But with bike riding, actually, often it's that first step of understanding how to begin pedaling without falling. That is the key. So it may not actually be about balance or strength. It might actually be about lack of task knowledge, or it might be that the bike the child is attempting to ride on is completely the wrong size, or the surface that they're trying to ride it on is really challenging. So that's why it's really important for us to understand exactly what's happening for that child, for that goal, and where they're doing it, as opposed to just assuming whatever's happening for that child is the thing that's holding them back from achieving that goal. And without actually observing, what that individual client is currently able to do, it's really impossible for us to fully understand how we can best support them to achieve their goal. And this observation and I suppose calibration of the goal should be done at each session when we see clients so that we understand where the child is up to as they make progress, so we can make really relevant adjustments to the intervention and the plan along the way. Recommendation 3 is that intervention should involve active practice of the goal. So the words active and passive are often used in cerebral palsy research and practice, and this is because many of the approaches that were commonly used 20 to 30 years ago were passive approaches in which the therapist handled the child to facilitate potentially normal movement patterns like NDT and bow bath, for example. But best practice has really progressed since that time, and we now know that clinicians, as much as possible, should use a hands-off approach, really providing opportunities for the child to actively and independently practice the task that they're wanting to do. And this is because active practice is what induces that neuroplastic change. And in fact, we also know that neuroplasticity is not only enhanced by the client actively carrying out the task, but also by the task being really meaningful and really challenging to that client. So neuroplasticity is not as effective when we just repeat a menial task, such as reach and grasp over and over, compared to if we're practicing our goal of being able to make a cup of coffee for ourselves and drink it, for example. So in addition to active practice, it's also really important to practice the whole goal where possible. So as clinicians, we often have this great ability to break things down to make tasks easier for our clients, but research is now telling us that the most effective and efficient way to achieve a goal is to actually practice that whole goal in its entirety, if that's possible. So for example, in research related to hand skills, we did a study sort of on dose and that sort of thing when 3 goals were set. Intervention that focused on practice of the whole goal required on average practice 14 hours of practice to achieve goals, compared to interventions that broke the task down requiring on average 30 to 40 hours practice. So more than double, almost triple the amount of practice to achieve those goals. So as much as possible, we should always aim to start with practice of the whole goal rather than assuming that we need to break it down. Of course, this isn't always possible, and if the goal is broken down into part task practice, intervention should really be followed by whole task practice of the goal once the child is able to do that. It's also important to note here that clinicians can assist children by really encouraging child-led problem solving and identifying where task achievement is unsuccessful and providing feedback on how task performance can be improved. And this is really in line with evidence from the education literature about how we as humans learn best. So we don't learn best when someone gives us step-by-step instruction, and in fact, we often can't repeat the task when that's the case. We actually learn best when we do the thinking and have, I suppose, that light bulb moment of realizing how to do something. And it's when we have that moment or our clients have that moment that they're then more likely to remember and to be able to do something again. Recommendation 4 is that intervention should be enjoyable and motivating for the child. So if the child is crying or distressed, the clinician should stop and comfort the child and change the intervention to match the child's needs and preferences. So this recommendation might seem really logical, but there's a lot of new novel interventions out there that could be tried. And if you're a clinician who does this, then it's really important to be in sync with the child and ensure that it's a really positive experience, I suppose. And this is not to say that the child should not be challenged. And, there's frustration in learning any new skills that are difficult for us. But if a child is upset, it's really unlikely that there's going to be any beautiful, long-lasting benefits from that intervention. Recommendation 5 is that practice of the goals should occur within the child's home or community environments. So functional training is really maximised by considering the context of practice. So achievement of the goal is more likely to be carried over into everyday life if it's actually practiced within everyday environments such as the child's home or community. And this is really the ultimate aim, right? Because, what's the point of the child being able to transfer from a plinth into a chair in the clinic setting if they can't actually transfer into their own bed or onto their own toilet at home? So this really comes back to the importance of focusing on the child's participation in important life activities rather than focusing on therapy for the sake of therapy. So we know that it's not always possible for practice to happen within the child's home or school or other community setting. And for many clinicians, we might see kids in a clinic environment. But this doesn't mean that we shouldn't consider the context. So when it's not possible to carry out the goal or practice the goal within that real life context, we should try and make practice happen within an environment that simulates real life as much as possible. So this might mean things like going outside to practice walking or driving the wheelchair on different surfaces, or getting the child to bring their own equipment in from home, so their own basketball or their own cutlery, if that's what their goals are based around. And having a discussion with the child and the family about when and where practice can happen is really key to goal achievement and carryover of participation within the child's life outside of that clinic environment. And recommendations and plans for practice at home, should always be shared with the family, whether that be in a written format or a text or however you communicate with families in that way. Recommendation 6 is that parent-delivered intervention is a really key component of all intervention. So it's really important for this recommendation, I think, to keep in mind that each family will have differing resources and capacity to practice at home, and we absolutely don't expect parents to be therapists, but it is important for us to share our knowledge around what works. And we know that practice needs to happen regularly for goals to be improved, and that coming into therapy once a week or once a fortnight won't lead to is unlikely to lead to improvements without practice in between those therapy sessions. So research shows that supplementary practice of goals at home with parents. So for example, 50% of practice with a therapist and 50% of practice with parent can be just as effective as 100% of that practice happening with a therapist. And for families who can carry out practice at home, it's likely to be more cost effective and may have less time and travel burden on families, keeping in mind, of course, that all families have differing preferences. So to facilitate parent-delivered support of practice, as clinicians, we can provide appropriate education and coaching and information. So families feel really empowered and confident carrying through on recommendations at home. We can provide a structured home program, which really involves direct practice of the child's chosen goals, which we touched on the previous slide. We can offer ongoing review as well as child and family support. So this support and review can be adapted according to the preferences of the family. So you might phone them to touch base or send a text or just let families know that they can contact you in between appointments, you know, if they have any questions. Sometimes just knowing that they have someone to call on can give families greater confidence, even if they don't necessarily make that call. Recommendation 7 is that children and parents really should remain the decision makers throughout the intervention. So this involves us sharing our knowledge and really empowering families to feel confident that they can make decisions about what works best for their child and their family at that particular point in time, rather than feeling like they have to depend on the advice of all the health professionals involved in their child's care. It's you know, it's hard to imagine as a health professional what it must be like to be the parent of a child with a disability when there's always another goal, another intervention, and never enough time to help their child in any and every way that they can. So we know that parental engagement is a really key factor in the success of any intervention. And in fact, you know, that therapeutic relationship can be a greater predictor of satisfaction and therapy outcomes than the actual intervention that has been chosen. So we should really take time, you know, to get to know the child and the family and to understand more about them as a family and how our involvement can best support them. So using really open-ended questions such as tell me about your family, or I'd love to know more about, you know, what your child enjoys doing, and really allowing families to share their story will really build respect from families and ensure that they feel heard. It's also really important for us to reinforce to the child and the family that they are the experts in the child and their family, and that knowledge is really, really invaluable. And that, you know, taking time away from therapy and focusing on their family is actually okay, and in fact, really, really important. So we have a responsibility to provide families with up-to-date evidence to really enable them to make informed decisions about the best interventions for their child. So no longer is it about us as health professionals, you know, being the all-knowing experts and simply telling children and families what they need to do. It's really about us sharing our knowledge about health conditions and what the evidence is telling us works best for the goals that the child and family have, and then empowering families to feel like they can make decisions about what works best for their child and their family at that point in time. And in doing this, it's really important as health professionals, I suppose, for us to take stock of our own preconceptions and ensure that we really allow families to make their own decisions without judgment, even if their decisions aren't necessarily the same as what we would personally choose. So in addition to sharing our knowledge, being really non-judgmental and empowering families to make decisions, it's really important that we don't use, I suppose, a cookie cutter approach to intervention. So that is, intervention recommendations should really be tailored to match every individual client that we work with, their ability and their potential, as well as the family's capacity and preferences, to ensure that the intervention is likely to be effective. So when we're supporting families to make decisions about the most appropriate interventions, including, you know, the timing and content of interventions, it's really important that we consider individual factors such as age and ability level, the resources that are available. And in doing so, we should only really suggest feasible, acceptable, and effective interventions. So this is something that's, you know, really important for us to consider for those families who really want to do everything for their children. Unfortunately, there's some interventions out there that might be both costly and time consuming and might not actually have any research behind them to suggest that they actually make any difference to the child's life. And it's our role to inform families about the research and evidence behind those interventions. Recommendation 8 is that a high enough dose of practice needs to be undertaken in order to achieve functional goals. So unfortunately, there's no hard and fast rule in regard to dose or frequency of intervention. And this will really vary depending on the type of intervention chosen and the goal and the child and the family actually. So we need to consider how an optimum dose of intervention can be achieved when we're planning the intervention, including face-to-face therapy and home practice. And in fact, this discussion around how much practice can occur really needs to happen when we're making a decision about the most appropriate intervention, rather than after you've decided which intervention as a health professional you might feel is best. So this is because we know that certain interventions require more or less practice, for example, and for some interventions there are really specific guides out there around how much intervention should be planned for the intervention to be most likely to lead to success, and constraint-induced movement therapy is a good example of this. It's also really, really important for us to let families know if a high enough dose of practice is not achieved, then an intervention is unlikely to lead to achievement of the goals. So families can then make the decision about whether the goal is a high enough priority at that point in time to commit the time and effort needed. I think within the structure of NDIS in Australia, some children and families and clinicians can get into this groove of weekly or fortnightly therapy. But we know that if intervention is only happening once a week or once a fortnight without practice outside of those times, that we're really unlikely to see many improvements. So it might be really, really important to consider how funding can be utilised in alternative ways to ensure our interventions are actually effective. So, for example, considering a block of twice weekly intervention when families have the time to dedicate practice, and sometimes school holidays might be a nice or realistic time for families to do this, and then they can have breaks in between those blocks of intervention. Recommendation 9 is that a team approach to setting goals and making decisions regarding intervention regimes can really streamline services and prevent overburdening of families. So this seems simple, but it's really hard work and time consuming to communicate with everyone who's involved with a child and family. And because in Australia, most children and families are lucky enough to have access to many health professionals to support them. And we all have, these amazing different skill sets, physios, speechies, OTs, dietitians, psychs, for example. There's also the risk that, each of these different disciplines set separate goals and make separate recommendations. And even if, each of those clinicians gave the family 1 or 2 goals to work on, that would mean that child and family are working on 5 to 10 different goals at any one time. And I don't know about you, but that sounds super overwhelming to me. And actually, research tells us that that many goals isn't realistic to work on at any one time. So burnout and a real lack of motivation are likely to be the result of that many goals being set. So the team around the child and the family really need to support that child and family to figure out what's the most important thing for them to work on at that point in time. And we recommend setting a maximum of 3 goals, which are really prioritised by the child and family, with intervention and home practice focused on these goals. And it's so easy to slip a few extra suggestions or exercises or whatever in there, right? But it's really important as health professionals to try not to do this, because families will have constant guilt about not doing them. So this idea of the child and family prioritising goals can be tricky, because at times it might mean that, as the OT or the physio or the speechy, what we think is most important and relevant from our own professional viewpoint isn't necessarily the priority. And indeed, it might be that we're not involved in the intervention for specific goals. And this is hard because we probably always feel like we can make a really important contribution, and that there's something that the child can improve on from our perspective. But, it's not about us as individual disciplines. It's about really ensuring that the child and the family are supported to achieve their goals, and importantly, that they don't feel overwhelmed by a really unrealistic amount of recommendations to follow. So how can we actually work as a team and prioritise these goals in practice? Well, we can let families know that it's really important not to try and work on everything at once, and try and connect with others that are working with the child and the family to communicate around current goals and intervention plans. So ideally, goal setting would be done as a team, even if it's just one person that's representing all the clinicians involved. And then each clinician's involvement is really led by the current goals and priorities. Again, this might mean adapting your current service provision model. So when we talk about a team approach to intervention, we really consider the child and the family at the centre of that as, important key members of that team. And like we've spoken about, we're really aiming for children and families to feel empowered enough to take initiative and make decisions in their own best interests. So now I've spoken about the 9 key principles of intervention that the guideline recommends, and I'm going to briefly cover those interventions that are currently supported by evidence, specifically when there are goals related to mobility and hand use, as well as self-care and participation in leisure activities. So if there is a functional goal that's been set and you as a clinician are using an intervention that isn't mentioned here, it would be great to begin considering how you could adapt your own practice and try to utilise interventions that are actually supported by evidence. So there are numerous interventions that can improve gross motor abilities, although surprisingly the evidence is actually lacking in this area. So research has shown that both treadmill training and overground walking can improve walking speed and distance. And because not everyone has a treadmill at home to supplement walking practice, it's recommended that overground walking be used with supplementary treadmill use to increase the dose of practice. And for some young adults, heading to the gym and jumping on the treadmill might actually be something that they really enjoy. And on the other hand, they might not be into it, and that's fine too. So Habitil, which stands for Hand and Arm Bimanual Intensive Therapy, including the lower extremity, has also been shown to improve walking speed and distance, although it requires a much higher dose and it can be quite therapist intensive. But if it's available, it should improve mobility. For other gross motor goals, it's really recommended that a goal-directed or context-focused approach be used. So for things like standing transfers, it's recommended that, practice of the actual transfer in real-life situations be undertaken rather than addressing underlying impairments such as leg strength or core strengthening activities. So I'm just going to briefly mention those specific interventions that we have recommended for each of these different functional areas. So overground walking is exactly what it sounds like. It really just involves practice of walking within real life environments within whatever terrain the child needs to walk in within their everyday life. So overground walking isn't always possible, and I think many therapists might identify that this is a barrier as they're only able to see clients within the clinic environment, but perhaps we could think about how we could be a bit more creative about doing this. So maybe even just going outside the clinic environment, or thinking about, setting up the terrain so it reflects, the person's actual goal. So it's really, really important to come back to what the goal is, and at a minimum be ensuring that you understand when and where and the type of terrain that the child wants to walk or run in. So the use of a treadmill can make practice easier for families. Families have reported that, but it might not always be an option, particularly if we consider these guidelines within the context of low resource settings and parts of the world that don't necessarily have access to equipment. So treadmill training can be done in a traditional sense. So with the young person on the treadmill holding the handrails, similarly to what we would do if we were at the gym, but there's also now various options for supported treadmill training. So bodyweight supported treadmill training is when the child or the person's body is supported by some kind of system. There are quite a few different support systems out there, and they offer quite varying levels of support that can be provided to facilitate walking whilst on the treadmill. So if we come back to some of those key principles that we've just spoken about that are most likely to lead to achievement of a functional goal, things like practicing that goal within a real life context and the child being as active as possible in carrying out that whole goal, you can see when we introduce things like treadmill training with lots of support systems, like, if we're taking away from the child weight bearing and the child might not necessarily be doing the actively taking steps themselves on the treadmill, that this becomes further away from that real life whole task practice that we know is the most efficient way to achieve a functional goal. And there's now a few systematic reviews out there that show that bodyweight supported treadmill training might not lead to gains in actual mobility, and that the equipment can be expensive and not very accessible to people, as well as potentially, for some kids may not be enjoyable. And this really highlights why it's really important to come back to what that functional goal is and what the child or young person wants to achieve, and whether the interventions that we choose are most effective in achieving those goals. Particularly probably particularly when we consider functional goals around mobility for children with more severe physical impairment, because the likelihood is that they'll continue to be dependent on equipment for mobility, even if we carry out these interventions. I know that there has been other health benefits that have been found from doing things like treadmill training. So these are important things to consider too, but it's also important for us to be aware of the fact that if the goal is around mobility, this treadmill training might not be leading to improvements in that specific goal. So context-focused interventions have been shown to be effective in improving mobility as well as other functional goals. And you'll see as we work through these interventions that there are common interventions that can achieve goals in different areas, although some are really specific to things like mobility and hand skills. So context-focused intervention is a top-down approach that sets client-centered goals and works directly on those goals, and is very functional and activity-based. So in context-focused interventions, there's a focus on changing the task and the environment rather than trying to change anything about the child. So in this intervention, clinicians explicitly do not attempt to change any underlying impairments such as balance or sensory processing or joint range. But you might consider carrying out the task in a different way or using compensatory strategies or techniques. So there's been lots of research regarding hand use, and this is the area probably that is most supported by the highest level of evidence in the CP population. So when a child or young person we're working with has a goal related to using their hands, we know that goal-directed and task-specific approaches are most effective. And you'll definitely be seeing a theme here. So if really for all areas, a goal-directed and task-specific approach in which the child is actively carrying out the activity or the goal, so the therapist is using a hands-off approach as much as possible. So there are a number of specific interventions that can be appropriate when there's goals related to hand function. So these can include constraint, bimanual interventions, co-op, habit and Habitil. So to make a decision about which of these interventions is most appropriate, it's really important to consider the child and family's preferences, as well as the child's age and ability and the context and the current resources. So for children who are max 4 or possibly max 5, a goal-directed approach should really be combined with environmental adaptations and equipment to maximise independence. Oh, this slide's done something funny, sorry. So because there's so many different interventions, we did develop this algorithm to help people make decisions around which type of upper limb intervention is the most appropriate. So we can't see it properly on this slide, but if you refer back to that guideline, you'll be able to access that algorithm, the published guideline. Otherwise, if you can't, let us know, reach out to us and we can share it with us. But like I said, it's always really, really important for us to consider individual factors, including the child and family's preferences, the type of goal, their cognition and behaviour, and available resources when we're making a decision about which intervention is most appropriate. So most people are probably pretty aware of constraint-induced movement therapy or modified constraint-induced movement therapy, or what I will just call constraint. So it involves restraining the child's less affected hand to really encourage the child to use their more affected hand during tasks that are specifically set up for each individual. So whilst constraint it used to involve casting the less affected hand for a prolonged period, we now know that a more child-friendly form of constraint in which the child only wears the restraint during the actual practice of the tasks can be just as effective. Because we know that it's the actual practice that is happening with the more affected hand that really is the key to inducing neuroplasticity and improvements in function. It's not the restraint of the better hand. So constraint's really fantastic for those kids who are not using their more affected hand to their full potential. So those with a very limited movement on their affected side, constraint might not be the most appropriate option, as it's really challenging to find age-appropriate toys, and children who, for example, don't have active wrist and finger movement will become really frustrated easily, because restraining their less affected arm will take away all the function that they do have. So research evidence now also suggests that it's really important, following a block of constraint, that we then do a block of intervention that includes whole task practice to ensure there's carryover of those beautiful skills that we see after constraint into everyday life and activities. Bimanual therapy is an alternative to constraint when the primary goal is really to improve use of two hands together rather than the focus being on the more affected hand. So it might also be an appropriate choice for children who don't tolerate wearing a splint or a restraint, or who might have really limited movement in their more affected hand. So bimanual therapy involves selecting activities and really setting up the environment to promote spontaneous use of both hands. So in some ways it can be more challenging for the clinician to carry out than constraint is. So similar to constraint, bimanual interventions require sort of 30 to 40 hours of practice, including home practice, to be effective. So Habitil is a specific form of bimanual therapy, and it now involves the lower limb, which is really fantastic as it can address, all of the child's goals as opposed to just focusing on upper limbs. So Habitil is an intensive program and often runs during the school holidays, in which children attend full days of intervention for 3 weeks in a row. Children set their own functional goals, and habit really involves active practice to encourage improvement of underlying movements and abilities in addition to practice of specific goals. And I know that Leanne, actually, who's here with us today, they're running a preschool Habitil program, so it would be great if people are interested to hear a bit more detail about exactly what that entails in terms of time commitment and that sort of thing. So to improve function in self-care goals, so this is for all motor types and severities of cerebral palsy, it's recommended that a goal-directed and task-specific approach be used for skills development, and that this be combined with adaptive equipment to promote really safe and timely independence. So goal-directed training, co-op and Habitil are effective interventions for achieving self-care goals. So equipment is not an intervention to improve function. However, it definitely in this guideline is a strong recommendation that equipment be used to improve independence and safety, as well as decreasing caregiver burden. So if there's equipment available and it's acceptable to the child and the family to use that equipment, it doesn't make sense to necessarily put time and energy into carrying out self-care tasks without these supports. And of course, in many parts of the world, that equipment might not be available. So, if the child's goal is being able to dress and undress themselves for toileting, you'd practice that a whole actual task, ideally within the bathroom that the child's going to be doing, or the toilet that the child's going to be doing these things in, and consider not only how the task could be changed, but what the child could practice, or, you might also consider whether something as simple as a handrail in the bathroom could help, or the type of clothing that a child wears might make a difference, so elastic banded pants rather than a zip or a bun, for example. And along the way, of course, ensuring that any adaptations or equipment that we might suggest are acceptable to the child. You might not be able to change the type of pants if it's a specific school uniform that the child wants to or has to wear. The co-op approach, along with goal-directed training and Habitil, can be effective for self-care goals as well as other functional goals that the child might have. So the co-op approach focuses on whole task practice of the client's chosen goals, and it differs from other goal-directed interventions in that it first focuses on teaching the client the global problem-solving strategy of goal, plan, do, check, and then the therapist guides clients through a process of guided discovery to get the client to identify where the task is breaking down, and also get the client to actually come up with possible solutions to the task rather than the therapist providing step-by-step instruction or telling the client how to do these things. And through this, the client then learns how to apply this goal, plan, do, check process to future goals or tasks, hopefully without necessarily needing to rely on support from a therapist. So to be appropriate for co-op, children need to have goals that they themselves have set and they're really motivated to practice. So they also need to have sufficient language to communicate and problem solve, although this might be through a communication device, which is absolutely fine. And children need to have, I guess, the behavioural responsiveness to problem solve, including the ability to maintain attention for short periods. So co-op might require less practice than some other intervention, but it does require training. Recommendation 13, the last recommendation, for children and young people with cerebral palsy, when a leisure activity is the focus of intervention, clinicians should combine interventions to improve function with a focus on supporting the individual to overcome any environmental, personal, and social factors that might be limiting participation. So leisure activities are more about participation than some goals around hand use, mobility, or self-care might be. And to facilitate this participation, it's really, really important for us to consider the context of of the child's goals and what it is that might be stopping participation, as well as those things that might help to overcome these hurdles. So there's really emerging evidence for a number of interventions that can be effective in facilitating participation in leisure activities. And you'll notice that none of these focus on addressing underlying impairments, which, you know, when we're considering a child wanting to participate in basketball or soccer, we might automatically think about beginning to work on getting stronger and fitter in our therapy sessions. So the pathways and resources for engagement and participation, or PrEP, in this interventions, clients set their own goals, and it really focuses on enhancing participation through modification of the environment and the task rather than trying to change any aspects of the child. So you'll notice it's similar to that context focused intervention that we spoke about earlier. And in PrEP, you really work with the child and family within their home and community environments, and it's specifically set up as a 12-week intervention. I've got a little link there. There is training for PrEP on the CanChild website. There is a cost, I think it's around about $300, the cost of it. So PrEP really focuses specifically on barriers, whether they be environmental or social or otherwise, and works through these barriers with the child and the family to come up with strategies to overcome the barriers. So in PrEP, there's no focus on changing the child, which is a pretty different approach to what many of us might have been taught at uni or even do in our current workplaces. As I mentioned, there's a link there if people are keen to find out a little bit more information, and the training is fairly cheap and accessible. Participate CP has some similarities to PrEP. However, it uses more of a toolbox of interventions that can address all aspects of the child, so as well as the task and the environment, rather than just focusing on environmental barriers and facilitators. So Participate CP is a program that was developed in Australia by Sarah Reedman, who's a fantastic physio from Queensland, and she actually carried out her PhD on this intervention. So in Participate CP, children set their own goals and the clinician really works through intervention options based on the best available evidence. And that might include task-specific practice of the goal, changing the task, or addressing those barriers similar to what would be done if we were using that PrEP intervention. So there are numerous coaching approaches that therapists might use, and evidence really shows that combining coaching with addressing environmental barriers is definitely effective for participation in leisure activities. So there was a research study by Law and colleagues from Canada that came about really as a result of previous research showing that addressing body structures and functions as well as activities didn't necessarily have an impact on participation. So even if the child was able to throw and catch and shoot and dribble a basketball, they weren't necessarily meeting their goal of playing basketball with their friends at school or joining a local basketball team. So you can see that for leisure activities, the focus is really much broader than the child simply acquiring a skill. These interventions are about participation and all those factors that might impact on participation. And I think that it's really important, you know, in all the interventions that we do to consider how our intervention will actually carry over into everyday life. So, you know, kids being able to be kids and do all the awesome things that make them happy. So as we've made our way through these recommendations, I suppose you might have been thinking how these recommendations can be applied to children with more severe physical impairments. So those who are GMFCS and max 4 or 5, and this is a really relevant point. I think there's very little research out there telling us what is best practice in intervention with these kids and young people. So it can be a really real challenge, I think, to see how these guidelines can be adapted to suit this population. And I think we definitely need more research in this space. But I also think we can probably challenge ourselves to think about how we can keep true to some of those best practice principles of client-centered goals and really empowering families and thinking about practical strategies to support direct practice and achievement of the goal rather than focusing only on underlying impairments and component skills. And we've been doing some work with this group in Brazil around implementation of these guidelines, and they just have the most beautiful examples of how these best practice principles and setting goals and really directly addressing those goals can be so fulfilling for some families of children with more severe physical disability, and how this can make such a difference to their family dynamic and how happy they feel when their kids are compared to when the intervention is focused on primarily focused around impairments. So some of the recommendations that we've discussed might seem like really logical things that you do all the time in your practice. And if that's you, you're amazing and keep doing it. But perhaps there's some things that we've mentioned today that you could challenge yourself to reflect on in your own practice, and think about small things that you might be able to do to align more closely with these guideline recommendations. So I'd love to put a few questions to you for consideration, I suppose. You know, do you feel like you as a clinician lead children and families in goal setting by identifying things from your professional perspective that you feel should be worked on in therapy? Or do you ask children what is most important to them, or do families generally lead that goal setting? Do you feel like you take a step back when the goals of the child are not relevant to you or your specific discipline? And actually, do you stop yourself from making suggestions about any of those additional things that they could just keep working on in the background? And, you know, do you focus on the whole goal, or do you automatically think about the underlying skills that might first need to be addressed in order for the child to attempt their goal? Or do you consider that context of practice and make sure that practice is really directly relevant to the goal, in addition to making a plan with families around when and where and how practice can happen? Because there's a big difference between, you know, just giving a home program and having a really specific discussion about when and where practice will happen. And we know that the latter is much more effective than just handing over a piece of paper with recommendations on it. And you know, finally, I suppose, do you choose interventions that research is telling us that are actually effective? And if you don't, why is that? Is it because you feel more confident with other interventions, or is it what you've always done, or what your workplace has always done? Or, you know, are you not trained to carry out some of these interventions that we've discussed today? And is that what's stopping you from trying them? And if any of these things is the case for you, you know, what could you do to overcome some of these things perhaps and try these interventions that research is telling us are much more effective? So I'm looking forward to having a bit of a discussion with you guys about those things. So finally, I thought I'd just mention that there have been a couple of information sheets developed for clinicians and for families that are based around the recommendations in this guideline, and they're just freely available, and we can share them with you today, or you can just go directly to that link there. So you're welcome to use or share these information sheets as you see fit. They're on the CPA website, and if you Google functional training guidelines cerebral palsy, they will come up, and all the other information, so including that full published guideline, are on that site as well. So so we sort of hope that these will help clinicians maybe reflect on their own practice, but maybe also guide and empower families to ask questions and make sure services are really meeting their individual needs. So thanks so much. I'll stop sharing my screen now, and I'm looking forward to having a discussion with you guys. My email address is there, so if you've got any questions or want to follow up with me, please do email me.
Thanks, Michelle. That was very comprehensive and amazing. You can condense what's written in hundreds of pages to